Yeah, thanks, Michi. A warm welcome from Germany to everybody. I am a GIST patient myself and a board member of the German Sarcoma Foundation and of SPAEN. And in that function, I'm here as a chair today for this first session where we want, as Michi already mentioned, put a spotlight on 3 different topics. And I've seen that all speakers are checked already in. So we will go as planned, first starting with Paolo DeiTos from Italy, who will tell us something about the new WHO classification for sarcomas, what we get from there. So Paolo, if you are there, please come forward.
Yes, I'm here. And of course, I suppose I need to share my screen at that point. And while I'm doing that, I also wish to thank all SPAEN for this kind invitation. Hope you can see my screen now somewhat.
Yes.
And I was told that I have like approximately 15, max 20 minutes, which is, not much time to cover what we didn't know. But I mean, that will be more than enough to give you some taste of what has been done. But of course, I mean, there is many things that's been changing. So, of course, it's a privilege to talk to all of you. And I wish also to thank you, all of you, for amazing work that you have been doing during the last decades, at least. Yeah. So as you know, soft tissue sarcomas are kind of heterogeneous, rare. You know that they tend to be aggressive. You take all the mesenchymal malignancy, we know that there are many now, more than 80 distinct histotypes. We all know also, because we have discussed several times this issue, that both rarity and heterogeneity tend to affect diagnostic accuracy. So we are trying to do our best just to improve the quality of diagnosis in order to provide you with the best option in terms of therapies. Because in the end, why WHO is relevant? Because, morphology is the backbone of any clinical decision making. And of course, there is diagnosis, there is the need for prognostic biomarkers, predictive biomarker. And in all these contexts, conventional morphology, which means the use of the microscope, is still very powerful. Of course, when increasingly integrating with other techniques like immunohistochemistry, when you use proteins, the antibodies in order to detect proteins, they will tell us something more about the nature of the disease. And this also applies, of course, to the use of molecular genetics, which has been, of course, introduced at least 10 years ago, and now is getting more and more relevant. But sarcoma classification is based on morphology, and as you know, and of course, it has evolved through the years, and it has evolved also, my age has evolved, because I've been involved in WHO classification since 21 years now. And this was Lyon 2002, this is Zurich 2013, and that was like a couple of years ago, 1 year ago actually, Lyon for the last edition. And since the 2000, many changes has been introduced. We don't need to get through the very much of the details, but just to give some highlights, just think that a couple of lesions known as malignant fibrous histiocytoma and hemangiopericytoma in the 90s accounted for almost 70% of sarcoma diagnosis. Now they're all both gone. I mean, so which means that we had to find better names for at least 70% of the lesions. And of course, when you have a new WHO, you will get new entities. I will give you some examples, and also some changes in nomenclature. For example, now we will have a typical chondrogenic tumors, which means, that in the appendiceal skeleton, if you have a, let's say, chondrosarcoma grade 1, it's far better to call it a typical chondrogenic tumor, because the curettage is exactly the same you need to do for an enchondroma. So there is no need to use extra aggressive terms when you know that basically the behavior of the lesion is extremely indolent. And I mean, the therapy is exactly the same as for a benign chondrogenic tumor. And of course, there is a big discussion going on how much relevant is genetics in terms of definition of disease nowadays. You know, as a pathologist, I think morphology is the way to guide. There are exceptions, of course. If you take the example of central nervous system tumors, to be honest, the neuro-oncologist is more attracted to IDH1 status or MGMT status more than the specific diagnosis. But this is the exception to the rule. So the new WHO classification of sarcoma is mostly related to morphologies, but I will see the exceptions. So, and this is to give an example. I mean, of course, we can change the name of this very exotic sarcoma called extraskeletal mixed sarcoma into NR4A3 rearranged sarcomas. But then the truth is, we don't really change anything. And you know, it is true that the name, I mean, it's true that mixed sarcoma is not a chondrosarcoma, but it's also true that maybe in 6 months, people will report a new gene fusion in extraskeletal mixed sarcoma. So even, you know, the more fascinating, trendy, sexy name probably would be wrong at that point. So the issue is not to change the labels, but the issue is try to recognize things and to correlate them with clinical behavior and possibly with therapy, which of course sometimes not still possible. So the contribution of molecular genetics is very, very important, in particular when we start using so-called next generation sequencing, but we are doing next generation since 10 years now, so probably it's past generation sequencing. So it's better to use the good term massive parallel sequencing. We can do many things. We can validate classification, we can identify new diagnostic marker, which makes, you know, diagnosis equally accurate, but faster and cheaper. We can identify new tumor entities. We can help elucidating what is the reason for a sarcoma to be a sarcoma. And of course, hopefully to identify new potential targets. So for example, as you know, there is a lesion, as you may know, there is a lesion called pseudomyogenic hemangiendothelioma, which is a vascular neoplasm. Hemangiendothelioma means vascular. Pseudomyogenic because neoplastic cells looks a little bit like muscle fibers. And the important thing is that before we describe this entity, surgeons thought that these patients had metastatic disease from onset. And the truth is that these poor people had simply multifocal disease. So you don't need to amputate them. And now we know that a very, very, you know, conservative surgical approach is more than enough for this lesion. And, you know, when you describe me something new, it's nice to have to demonstrate that not only morphology fits with the entity and the clinical behavior, but also the genetics fits. That's why we create and how we create new distinct entities. And now the couple of examples are the new, totally new category within the WHO, which is the so-called undifferentiated round cell sarcomas, where Ewing's also is. But from the beginning, we knew, from many years ago, actually, this is more than, as you can see, 16 years ago, we had a suspect that some of the Ewing actually were not really Ewings. And now we know that one part of these lesions that, by the way, do not respond so well to the Ewing's protocol are the so-called chick rearranged sarcomas. Another half are the so-called B-core rearranged sarcomas. And, you know, these entities are defined on the presence, even if you can recognize them, but they are defined by the presence of a specific fusion gene, specific chromosome abnormality. But the important message is that there is some prognostic relevance and predictive relevance as well. So we know that chick ducts are far more aggressive than Ewing's. We know the B-core is less aggressive. So, of course, they are rare diseases. This is the 5% of the already rare Ewing's. But in a way, this is open the way to a different reasoning when you have to decide what kind of treatment to give these patients. In case of B-core, many times could be even no treatment at all. And of course, life is complicated. Just to share you some examples. So our French friends, in a way, they reported this new category of chick rearranged sarcomas with another molecule, which, by the way, is also a therapeutic target, like NATM1. But it's interesting just to know how challenging it can be, because the people who first reported NATM1, which is Chris French in Boston, which is, you should know what it is. They don't have the feeling that actually they are sarcomas at all. They may be actually carcinomas with this type of gene fusion. And again, this brings back the concept, how we define disease, because disease is not defined, in my opinion, through a simple genetic abnormalities. But again, we need to look at the clinic, we need to look at the morphology, we need to go, of course, on the molecular genetics and immunophenotype, but also the clinical behavior and possibly also to the possible therapeutic options. As it is when we started discussing many, many years ago of wild type Gs, so we first reported and tracked ATV6. We arranged in one gist. People may argue that some of these were are not gist, that this specific was a gist. It is very, very rare. But the nice things that we did in imaging at the time is open, the doors to the story of NTRK, who led also to the so-called agnostic approval from the regulatory standpoint of anti-NTRK compounds. And again, here, just for the sake of patient, I want to underline, agnostic is just the regulatory approach. It's not that we don't need pathology anymore, because NTRK can occur anywhere: colon cancer, lung cancer, sarcomas, of course, they're very enriched there. But before looking for NTRK, we need to have a diagnosis, and we have to have an expert pathologist, and then an expert surgeon, and then an expert medical oncologist, expert in the disease, not expert in NTRK, of course. So now we have in our field the very rare infantile phagocytoma and the extremely rare lipofibromatosis like neural tumor, which is most often benign but can be very big. So maybe downsizing with the drug can be helpful. And then a quite undefined group called tumors that closely resemble peripheral nerve sheath tumor. Anyway, those three targets are potentially eligible for therapy with anti-NTRK compounds. And this is one of the examples, the so-called lipofibromatosis like neural tumor, which is called so in this way just because it resembles morphologically lipofibromatosis, but it's not. And within our sarcoma community, we try, of course, to focus a little bit on how should we do and what should we do in order to pick up most of the cases, knowing that there are many, many different techniques. And so I think it's good compromise is the using immunohistochemistry to pick up potential candidates and then to prove, to confirm immuno with molecular techniques. It's a field that is evolving quite rapidly, but the point here is not to leave behind patients, even if these lesions are extremely rare. Personally, from the ethical standpoint, I think we need to do our best, of course, in an affordable way, to allow any patient to get the proper treatment. Then for the fun of fusion gene, you may know that every single morning we report new fusion genes in some kind of not so clear tumor entities. So this is just an example in which I can see things which are relevant, things which I don't think they are relevant. In fact, you won't find them into the WHO, because we don't want to confound people. We don't want to create a mess around these diagnostics. We don't want to have such a reaction in the sarcoma community with a couple of entities with a fusion gene, and we don't know the behavior, we don't know how to treat them, we don't know anything about them. This is just entropy. And in fact, so we try with Paolo Casali and Alex Ironchi to answer the question, when does a new sarcoma exist, which is a difficult question, of course, but can be simple the presence of a molecular biomarker, even a predictive biomarker. This is not enough. And as you know, I always show these type of things because many of you get in a way informed that if you do extensive profiling of the genome or the transcriptome of the methylome, then you sort out all the problems, which is, of course, sometimes true, but sometimes not true. So many of the lesions that are listed in this paper, or they're listed in a recent German oncology paper, actually they are simply, recognized by conventional morphology and conventional molecular genetics. What I mean, you don't need to look into hundreds of genes in order to make a correct diagnosis of GIST. That's the point, And but this is something that is always missing some of the recent discussion we had. And in fact, nobody's really seeing a real benefit in extensive genetic profiling, which it doesn't mean that I'm against, the idea to use genetics in order to find potential targets anytime. When, for example, people or our patient may fail on a given therapy, I think it's very correct to try to find something that could be used therapeutically into the next stage of the disease. But this is something different from saying, okay, any type of cancer need to have, like say 500 genes scrutinized in order to find anything. This in sarcoma has been done extensively in the United States, and the results are pretty modest, to be honest. This has been done in particular at the Dana-Farber. But you have also to consider that it could be unaffordable to have this type of approach. Another thing is that when the clinical conditions suggest it may be useful, trying that way, which is probably what we need to do in the so-called tumor molecular board. And honestly, if you look at the most recent data in sarcomas, when they try to use gene profiling instead of proper classification, well, the results are unsatisfactory. And also our friend Jenny also say, our data suggests that molecular profiling should not be used in routine practice, but warrants further exploration, which is of course always good. But at the very moment, for the decision we need to make every day, this is not the correct shortcut. But of course, research is another story, but clinical practice is something different, and we definitely want that all our patients get treated the best way we can. So in conclusions, soft tissue tumors are a global challenge because of rarity, because of intrinsic difficulty in diagnosis. We are, of course, using all the tools we have, including extensive genetic profiling. I personally believe that an excess in molecular segmentation may be potentially confusing. We need to provide entities which are linked in a way with reality. In this sense, WHO classification certainly on a global scale play a crucial role in order to improve the quality of pathologic diagnosis, and without diagnostic accuracy, of course, we cannot match the correct treatment. So this is bringing the end of my talk, and I wish, of course, to thank you for your attention.
Thanks for that fast overview, and you are almost in time, just 20 minutes. Very good. You already got a clapping hands from Catherine here.
Good.
I'm not sure, are there some questions, or is there somebody who wants to ask a question? Otherwise, we would go to the next. Just raise your hand. I don't see a hand.
There is one question, I think from Marcus. It is far too complex for most pathologists. It takes specially experienced sarcoma pathologists. What are your experience of first fall sarcoma diagnosis by regular pathologists? 20, yes, Marcus. As you know, 30% when we are lucky, but sometimes it's difficult to know because people who send cases, sometimes they simply don't make a diagnosis. And this is the good part, because in a way they know they don't know, in a way they seek for help. But even in our study on Conticanet, 30% is more or less the number of cases. So 1 in 3 don't get the correct diagnosis, which is of course a total disaster.